This is the 5-minute thesis session where it's an opportunity for the first year students to give a brief outline of their work, and there's going to be no question and answers in this, but it's really an overview of what you're going to be seeing over the next few years in these meetings. And Jyothika Kumar is one of our volunteers, has kindly agreed to chair the session. So I'll hand over to you, Jyothika.
Brilliant. Thank you very much. Mike, just a quick question. Do we want to give people the chance to ask any questions on the chat that the students can then answer, or?
Well, we could certainly do that if people want to ask questions that they could maybe pick up offline after the meeting, or answer in the chat in real time if they're capable of that degree of asking.
Brilliant. Okay, great. Okay, I'm just gonna find the agenda. Just a second. All right. Okay, I must admit I was much better prepared for this last year. So I actually emailed a few people to make sure I was getting their name pronunciations correctly. Haven't done that this year, so if I do make a bit of a mess of your name, then please do correct me if I get it wrong. So the first presentation is by Jane Hahn from UCL. And can I please invite Dr. Francesca Solmi to introduce Jane, please?
Hi, good afternoon, everyone. I'm delighted to introduce Jane Hahn. She is a first-year PhD student in the UCL Division of Psychiatry. She started in October last year. So as well as by myself, she's also supervised by Professor Glyn Lewis, Dr. Amy Harrison, and Professor Aileen Fleury. And James' PhD project aims to identify early life risk factors for adolescent eating disorders, and I believe she's going to tell us more about her research plans now. So over to you, Jane.
Thanks, Francesca. Hi, everyone. My name is Jane, and I'm excited to present to you the overarching aims of my PhD on early childhood adversities and its risks to eating disorders. So just to give you a quick background, eating disorders are severe psychiatric conditions characterized by unhealthy eating behaviors and obsessions with food, body weight, and shape. The most common types of eating disorders include anorexia nervosa, which is characterized by low body weight and restricted eating behaviors, bulimia nervosa, characterized by a cycle of binging and unpurging, binge eating disorder, which is associated with consuming large amounts of food in a short amount of time, accompanied by distress and pain, and other specified feeding or eating disorders, which is actually the most common type of eating disorders, but given as a diagnosis to people who don't fit the expected symptoms of the other eating disorders. Waiting lists for eating disorder treatment is often long, and it can span up to even 2 years. And when eating disorder symptoms are left untreated for a long time, they're going to have more serious mental and physical consequences. Therefore, prevention programs are really crucial to reducing the incidence and severity of eating disorders in the population. However, our understanding of risk factors that may inform these preventive strategies and early detection is still fairly limited, especially in early childhood. One of the most salient risk factors for mental health problems is childhood socioeconomic status, with few exceptions. For most conditions, mental health problems tend to be more common for children with parents from deprived groups. However, the role of socioeconomic status on eating disorders is relatively unclear. Many studies based on patients with diagnoses find that eating disorders are more common in affluent socioeconomic groups. On the other hand, when we look at eating disorder symptoms as a post-diagnosis in the general population, we find that these symptoms are more common in deprived groups. Some studies that look at periods of development in late childhood and adolescence show that lower childhood socioeconomic status is associated with disordered eating or eating disorder symptoms in adolescence. And this may indicate that deprivation also contributes to eating disorder symptoms, but only a select few are getting diagnosed. And this also calls into question what environmental adversities there are tied to socioeconomic status that are also contributing to the development of eating disorder symptoms in adolescents. And emerging evidence points to food environment. As we know, socioeconomic status affects dietary quality and accessibility. So those in lower socioeconomic groups tend to eat more processed diets or convenience-oriented diets, and have more unstable access to food. And this can in turn affect eating behaviors and their relationship with food. Another risk factor that has been mentioned is early mental health difficulties. And these early mental health difficulties include any emotional and behavioral difficulties, such as anxiety or hyperactivity. We know that these problems are extremely common for populations with eating disorders, and it sometimes precedes the onset of eating disorders as well. However, the impact of these risk factors have not been examined across multiple indicators of deprivation or from early childhood to adolescence, and with eating disorder symptoms in the general population as opposed to diagnosis in clinical settings. So my PhD will explore differences in eating disorder symptoms across different indicators of deprivation and whether secondary impacts of socioeconomic status, such as food environment and mental health difficulties in childhood, are associated with greater disordered eating symptoms in adolescents. And my hypothesis is that those in lower socioeconomic groups or children consuming processed diets and food insecure children will experience more eating disorder symptoms in adolescence, and that trajectories of early mental health problems will differ for adolescents with and without disordered eating behavior. In order to investigate these aims, I will be using the Avon longitudinal study of parents and children, or ALSPAC. ALSPAC is a cohort study including around 15,000 mothers and their children from the region of Avon with 24 years of follow-up from birth. And this really makes it the perfect data set to be exploring any childhood factors that might contribute to the development of eating disorder symptoms throughout adolescence. And we have currently put in the data request, and we're hoping to receive this data set in the coming weeks. So how will my PhD inform preventive strategies? I'm hoping to potentially uncover inequalities in eating disorder population distribution and treatment access. And I'm also hoping to identify risk factors that could be addressed by universal preventive interventions in schools and family settings. So this could be, for instance, nutritional support or supporting emotional well-being of children from families from deprived. Thank you so much for listening to my presentation, and a big thank you to my supervisory team as well. If you have any questions outside of the session, feel free to contact me on this email address. So,
brilliant. Thank you very much, Jane. Really clear presentation and very interesting research questions. So good luck with your PhD, and we look forward to hearing more about what you find in the coming years.
Thank you. It's such an honor. Thank you.
Brilliant. Okay, so our next presentation is from Sophie Chick, and can I please invite Dr. Elliot Rees to introduce Sophie? Thank you.
Hello, everyone. So it's my pleasure today to introduce you to Sophie Chick. So Sophie started her PhD last July, and she's supervised by myself and also Professor James Walters at Cardiff University. So Sophie is researching the genetic basis of schizophrenia, with a particular emphasis on identifying genes enriched for rare types of mutations in people with schizophrenia. And in quite a short space of time, she's already done an amazing job at understanding how to analyze very large and complex genetic data sets. And has some very interesting preliminary findings. So with that, I'd like to hand you over to Sophie.
Thanks, Elliot. I'm Sophie. As Elliot says, I'm in the first year of my PhD at the Cardiff MRC Centre for Neuropsychiatric Genetics and Genomics. And the title of my PhD is Integrating Microarray and Sequencing Data to Identify Rare Risk and Protective Genetic Variants of Schizophrenia. So it's a genetics-focused PhD looking at the types of genetic variation that contribute to schizophrenia. And I'm going to talk about the aims of my PhD and present some results from my first project. Schizophrenia is a complex disorder and its causes aren't well understood, which makes it difficult to develop drugs to treat it. There are three main mechanisms that are implicated by neuroimaging and clinical observations, which involve the neurotransmitters dopamine, glutamate, and GABA. So far, one of these mechanisms has been successfully targeted for drug development, which is dopamine neurotransmission, specifically at dopamine receptor 2. But these antipsychotics only work for about 70% of people. They don't treat all the symptoms of schizophrenia, and they can have distressing side effects. So there's a real need to understand more about the biology of schizophrenia so we can start to overcome the challenges of drug development and develop antipsychotics which treat more of the symptoms of schizophrenia in more people. And one way to do this is through genetic studies, which allow us to identify specific genes that are disrupted, like the dopamine receptor 2 gene. There are two ways of carrying out genetic studies. One is by analysing common variants, which make up the majority of our genetic variation and individually have small effects. And the other is by analysing rare variants, which are only found in very few people, but can have much larger effects. For common variants, the frequency of each variant is compared between cases and controls to find variants that are associated with having schizophrenia. And these are then mapped to genes that they are either in, nearby, or that they regulate. Some of the genes identified by common variant studies are shown here, and these converge on these pathways as well as a few others. Rare variants, on the other hand, are added up and compared within each gene rather than being compared individually. So this type of analysis can directly implicate genes, but it requires large sample sizes. So only a small number of genes have been identified this way, some of which are shown here. So you can see that at the moment, we're just beginning to scratch the surface of gene discovery in schizophrenia, and that identifying greater numbers of genes will require larger sample sizes. Which brings me on to the aims of my PhD, which are firstly to combine new sequencing data with published data to increase the sample size of this data and identify novel risk genes. Secondly, to identify protective variants in individuals who are at high genetic risk but do not have schizophrenia. And thirdly, to analyse rare and common variants jointly to implicate novel genes. And to briefly show some results from my first project. So I had access to new sequencing data, which is rare variant data, from 4,000 cases and 5,000 controls. In this sample alone, no genes were significantly associated with schizophrenia, which is what you would expect for a sample of this size. So I combined this with the largest rare variant study in schizophrenia carried out by the Schema Consortium for a total sample size of 28,000 cases, over 100,000 controls, and 3,000 parent-child trios, which is another way of comparing cases and controls that allows you to find newly derived variants. In the Schema study, they identified 10 genes associated with schizophrenia. In my combined analysis, I identified 11 genes, and only 6 of these overlapped with the Schema genes, so 5 of these are actually novel. And these are shown on the right with their functions, none of which have clear links to schizophrenia yet, but it's interesting to note that SRRM2 has already been implicated in neurodevelopmental disorders, and ACAP11 is implicated in bipolar disorder. So this is starting to tap into the shared genetic architecture between psychiatric disorders. And I'd like to thank my supervisors, Elliot and James, the wider psychosis group at the Cardiff MRC Centre, and I'm very grateful to Mental Health Research UK for funding my PhD. And thanks for listening.
And thank you very much, Sophie. It's pretty amazing that you've already managed to do so much in your first year. And of course, you've had access to this really rich data set. So yeah, really interesting findings, and it'd be nice to sort of see what comes out of it as you continue to sort of work on your project over the next few years. Thank you. Great. I think we're keeping to time very well, which is really good. The next presentation is by Tom Jenkins. I think Tom supervises but unable to be here today. Is that, I'm assuming that's still the case. So I will introduce Tom. So Tom has recently completed a master's in psychological science with specialism in clinical psychology at the University of Glasgow. Previously, he studied at the University of Birmingham and worked in clinical settings as well, including inpatient psychiatric care and a homelessness and addiction service. Tom started his MHR UK funded PhD at the University of Bath in October last year, under supervision of Professor Paul Chadwick and Dr. Pamela Jacobson. And the focus of Tom's research is the experience of dehumanization in people with psychosis who hear voices. So welcome, Tom.
Hi there. Yeah, thank you very much. Can you see the slides okay?
Yes.
Great, thank you. So yeah, hi everyone. My name is Tom Jenkins. I'm a first year PhD student at the University of Bath, working in the supervision of Professor Paul Chadwick and Dr. Pamela Jacobson. Yeah, the title of my project is Experiences of Dehumanization in People with Psychoses, Conceptualization, Measure Development, and Mindfulness Intervention. So the project has three main phases to it. The first of which is a conceptual review of the literature, which I'm currently working on at the moment. And this is designed to describe theories of dehumanization and experiences of psychoses, and then talk about how the two might be related, and how people with psychoses may experience dehumanization. The second part of the project then will be the development and validation of a novel measurement tool or a questionnaire designed to capture and quantify experiences or feelings of dehumanization. And the third and final part will be pilot testing this measure within a group-based mindfulness intervention. And this will see whether or not mindfulness can help reduce feelings of dehumanization. So what is dehumanization? Dehumanization is this feeling of being less than or other than human. It's a concept which has been historically researched within social psychology, primarily looking at how one social group dehumanizes another social group. But we're interested in the felt sense of that, particularly from the perspectives of people with psychoses. People with psychoses have reported that two main elements of their experience can be dehumanizing, one of which being the stigma and the stereotypes that surround the condition, and how that affects them with interactions with other people, particular like within society and interactions with other members of society. And then there's also the very nature and the content of the psychosis itself that can be dehumanizing. So for people who hear voices or experience auditory hallucinations, the very fact of having an experience that they may feel is different to that of other people can be dehumanizing, but also the content of that experience. So for people who hear voices, the voices may be belittling them or demeaning them, which can also be internally dehumanizing. Dehumanization or feeling dehumanized has been related to anxiety, depression, low moods, and lower subjective well-being. But what we found is that there's no way to measure this within a clinical setting, particularly no way that's been well validated. So this has become the focus of the second part of the project. We're going to be working on developing a novel measurement tool, which is effectively a questionnaire designed to quantify and measure these feelings. And this has two main phases to it. The first of which is an item generation phase, which is effectively where we come up with a list of questions we could potentially ask people. This will be both theory-driven and data-driven. So theory-driven will involve going through the literature, looking at experiences of psychoses and also dehumanization theory to come up with some questions we could ask. And the second part will be data-driven. A colleague of mine has recently conducted a qualitative study looking at experiences of dehumanization in people with psychoses. So some of the findings from that will be used to generate the initial pool of items as well. We will then use reliability and validity tests to cut down the number of items to make sure we're asking the most relevant questions of people. And this will also involve the opinions and perspectives of academics and clinicians, but also the input of people with lived experience of psychoses to make sure we're asking the most relevant questions. The final part of the project then will involve the pilot testing of this measure within a group-based mindfulness intervention. Mindfulness cultivates acceptance, awareness, and attention, and has been suggested to have perhaps a humanizing therapeutic benefit, particularly when practiced within a group-based setting. So we will be giving out the dehumanization measure both before and after a mindfulness for psychosis intervention. We'll also be giving out other measures of depression, anxiety, and stigma, as we're interested in whether or not mindfulness can reduce feelings of dehumanization, but also how this impacts other measures of mental health. The impacts or the implications, of this project should hopefully be to reduce stress and improve well-being for people with psychoses. And from an academic point of view, it should hopefully increase our understanding of experiences of psychoses, particularly by getting to this notion of dehumanization and what it is to feel dehumanized. This should inform the development of therapeutic interventions to help support people with psychoses and overall facilitate the provision of more humanizing care. Thanks very much for listening, and thank you to all at Mental Health Research UK.
And thank you very much, Tom. Really interesting presentation and very interesting study. I think all of us will be very keen to sort of hear more about your measure development progress, and yeah, definitely the feedback from your group sessions as well, the mindfulness sessions. So yeah, very interesting. Thank you.
Thank you.
Okay, so the next talk is by Una Coleman from King's College London. And can I please ask Professor Andrea Danesi to introduce Una, please?
Absolutely, thanks very much. So Una studied history of art at Cambridge University before psychological science MSc conversion course at UCL. And she started her PhD at King's College London in October 2021, supervised by myself and Dr. Kelly Rose Clark. And we're really grateful to the Mental Health Research UK for the opportunity to work with her and on an important topic. So as we will hear, her PhD project will use mixed qualitative and quantitative methods to understand the sources of disagreement between first-person and third-person measures of childhood maltreatment, and why mental health difficulty seems to be more strongly associated with subjective rather than objective experiences of childhood trauma, with the overall aim to promote resilience in the aftermath of traumatic childhood experiences.
Is Una here?
Una? We can't hear you, Una.
She is here, but I think Una, you're on mute.
You're muted. Una.
I'm so sorry about
Okay, great. Okay, we can hear you now.
Okay, perfect.
Yeah,
Sorry.
it was going back.
So the title of my project is Understanding Risk and Building Mental Health Resilience After Childhood Maltreatment, focused on the subjective experience. So maltreatment is a key risk factor for developing psychopathology throughout the life course. So therefore, identification of this group is important both for research and clinical purposes. And the measurement of maltreatment typically relies on information from a variety of different sources. And these can be divided broadly into third-person measures, which are collected typically during childhood, either by parents or official reports such as CPS records or court documents, and capture the kind of third-person perspective on whether a child has been maltreated. And in contrast to this, first-person measures are typically collected in adulthood, so retrospectively, and capture the kind of like subjective experience and self-report of maltreatment. So use of these different measures obviously relies on the assumption that they identify the same groups of individuals when they're kind of used interchangeably in research. However, that assumption has recently been shown actually to be incorrect. So a recent meta-analysis has found that first and third person perspectives actually identify largely different groups of individuals, and so therefore cannot be used interchangeably. So as you can see on this Venn diagram, over half of individuals with third person reports of maltreatment did not go on to kind of self-report the maltreatment in adulthood. And likewise, over half of individuals with self-reports of maltreatment did not have a concordant third person report. And as there's a well-established link between maltreatment and heightened risk of developing psychopathology, that kind of brings into question the relative contribution of these different reporting groups to the risk of developing psychopathology. So that was recently tested by my supervisor Andrea Danesi and also Kathy Whedon, and they kind of proposed two hypotheses. So the first one was that if psychopathology emerges because of the objective experience of maltreatment, then risk should be heightened in participants with third person reports of maltreatment, regardless of whether they also self-report it. And then conversely, if psychopathology emerges because of the subjective experience, then risk should be heightened in individuals with first-person reports, regardless of whether they have a corresponding third-person report. And that was the result that was found. So it indicates that elevated risk is only present among individuals with first-person accounts of maltreatment, regardless of whether they have third-person measures. And in contrast, the risk of psychopathology was no greater in individuals with only third-person measures in comparison to those who have no history of maltreatment reports. And this was similarly found for internalizing disorders such as depression, anxiety, and PTSD, and also externalizing disorders such as alcohol or drug abuse or dependence or antisocial personality disorder. So this indicates that psychopathology likely emerges as a function of the development of a subjective appraisal of having been maltreated, rather than the objective experience being in some way causal. So whilst the disagreement between different reports has been well established, the sources of this disagreement have been yet to be fully explored, which is what my PhD will seek to do, and to kind of examine the determinants of psychopathology uniquely associated with the subjective experience of maltreatment. And this is important not only because highlighting methodological challenges may provide insight into improving the conceptualization and measurement of maltreatment, but also understanding sources of disagreement between measures may help to identify protective and vulnerability factors towards developing psychopathology. So I'm currently working on a conceptual review identifying possible sources of measurement disagreement in the existing literature. And it's focusing broadly on three sets of mechanisms. The first being memory mechanisms. So that's looking at factors that might affect either the accessibility or accuracy of memories, influencing kind of self-reports in adulthood. The second is motivational reasons why an individual might choose not to disclose an abusive experience, or conversely, falsely kind of allege an experience that didn't occur. And the third group is issues inherent to the measurement of maltreatment, such as test-retest reliability. In addition, the main source of data that I'll be using throughout my PhD is the ERIS study, which is a population representative birth cohort following 2,232 twins since 1994. And it has 5 key assessment phases at ages 5, 7, 10, 12, and 18 years, with comprehensive assessments of psychosocial characteristics at each phase, as well as parent reports of maltreatment from ages 5 to 12 years, and first-person reports at age 18. So I'll be looking at between group differences using mixed method analyses, so both quantitative and qualitative, to highlight possible mechanisms of risk and resilience to psychopathology in the context of the subjective experience of childhood trauma. So thank you so much for listening, and thank you to my supervisors and to Mental Health Research UK for funding this.
Thank you very much, Una. Really interesting project. I think the ERIS cohort is a really rich cohort. So you're probably going to get some really good data from that one. So yeah, looking forward to hearing about your progress over the next years. Thank you very much. The next presentation is by Samantha Mitchell from the University of Cambridge. And can I please ask Professor John Simmons to introduce Samantha? Thank you.
Yes, thank you. It's my tremendous pleasure to introduce Samantha Mitchell, who's halfway through first year of her PhD, supervised by myself and Dr. Jane Garrison, and funded by Mental Health Research UK. Sam was an undergraduate at Cardiff University, where she studied for a BSc in psychology, and she stayed on at Cardiff for a master's in neuroimaging methods, for which she received a distinction. And then we were lucky enough to recruit her to Cambridge, where she's made a great start to her PhD, focusing on the neurocognitive basis of hallucinations in schizophrenia. Over to you, Sam.
Thanks. So, hi, I'm Sam. I'm going to give a quick introduction to my PhD on the brain mechanisms of hallucinations. Today, I'll focus on reality monitoring and paracingulate sulcus morphology. So reality monitoring is the ability to discriminate between information that is internally generated from information that is externally generated. And one of the main theories regarding the cognitive mechanisms underpinning hallucinations in schizophrenia is that hallucinations might arise due to a deficit in this reality monitoring ability. So where sensory information such as speech and images are perceived to be generated by an outside external source and so are perceived to be occurring in the outside world. So patients with schizophrenia have been found to perform worse on tasks of reality monitoring compared to healthy individuals. And deficits in reality monitoring ability have been associated with the presence of hallucinations in such patients. One area of the brain that is repeatedly associated with reality monitoring is the medial prefrontal cortex, and differences in activity within this area relate to individual differences in reality monitoring ability in both clinical and non-clinical populations. But within this area, research has highlighted a particular structure, the paracingulate sulcus. This sulcus is a tertiary fold, and the morphology of this fold can vary quite considerably throughout the general population. So here you can see examples of how the length of the paracingulate sulcus can really differ even in healthy individuals. And differences in this morphology have been associated with reality monitoring performance. So bilateral absence of the sulcus, meaning that it's not identifiable in either hemisphere, has been associated with poorer reality monitoring performance in healthy individuals. And in 2015, Garrison and colleagues found that a 1 centimeter reduction in the length of this fold in the left hemisphere was associated with a 19.9% increase in the likelihood that individuals with schizophrenia experienced hallucinations. So I'll now talk you through the first 2 research aims of my PhD. So firstly, I aim to further investigate whether there is a link between hallucination proneness and reality monitoring ability in healthy individuals, but more specifically, whether this link is modality general or modality specific. So does a proneness to hallucinations in a certain modality, for example, auditory, relate to reality monitoring deficits in that same modality? This modality general versus specific question is interesting because hallucinations can occur in a range of sensory modalities, but the prevalence levels differ considerably. The most common type by far are auditory verbal hallucinations. Comparing reality monitoring of different modalities may provide some insight into this disparity in prevalence levels. And secondly, I aim to extend the research in paracingulate sulcus morphology to adolescent age groups. So I want to utilize large data sets to analyze whether differences in paracingulate sulcus length observed during adolescent age may relate to early measures of psychosis, hallucination proneness, and reality monitoring ability. This is important due to the fact that schizophrenia generally starts to present in early adulthood and adolescence. And so we really want to utilize information from around these ages and younger to allow us to assess the validity of using such measures as predictors for subsequent onset of schizophrenia and hallucination symptoms. So to achieve this first aim, we adapted the commonly used reality monitoring task paradigm into 2 separate distinct tasks, which are able to measure visual and auditory reality monitoring ability separately. We then use a questionnaire to measure the hallucination proneness in each modality. And we're looking at individuals aged 18 to 25 years old, and the data collection for the study is currently in progress. Here you can see examples of the visual and auditory reality monitoring tasks. So in the visual task in the study phase, you are presented with either complete or incomplete celebrity and character pairs. When the pair is incomplete, the participant is required to vividly imagine the individual that would complete the pair. So here you either see ant and deck, or you just see ant and you'd be required to imagine deck. And then in the test phase, participants are asked whether the second individual was seen, imagined, or whether the pair is entirely new. For the auditory task, participants hear complete or incomplete word pairs. So if they heard Romeo and, they would be required to imagine the word Juliet. And later they need to make the same reality monitoring judgment. For my second aim, I plan to utilize 2 large adolescent data sets. The ABCD study and the NSPN cohort datasets are longitudinal studies of cognitive and behavioral development with individuals from age 9 in the ABCD study and age 14 in the NSPN cohort. So using the ABC dataset, I will investigate whether paracingulate sulcus length measured during adolescence correlates with early measures of psychosis. And with the NSPN cohort, I plan to recontact individuals of the cohort and ask them to complete a new online reality monitoring task. I'll then investigate whether paracingulate sulcus length measured from MRI scans conducted during their adolescence can predict their current reality monitoring ability. Thank you very much for listening, and thank you to Mental Health Research UK and the Rose Tree Trust for funding my research.
Thanks a lot, Sam. Really nice presentation, and thank you for showing us what the reality monitoring task looks like as well. That's really interesting to see. And yeah, again, looks like you're going to generate quite a lot of data from this, and be really interesting to see what you find. Thank you. Okay, so last but not least, we've got Nushin Sadullah Khani from UCL, and can I please ask Professor Elvira Brahman to introduce Nushin? Thank you.
Hello, can you hear me okay?
Yes. Yeah.
Great. Well, it's a pleasure to introduce Nushin Sadullah Khani. I'm very lucky that she's doing her PhD with me at UCL, and her co-supervisors are in another 2 universities, Professor George Kirov at Cardiff University and Dr. Barbara Barrett at IOPPN at King's College. And special thanks to Mental Health Research UK for making this multi-university collaboration possible and funding Nushin. Nushin is in her first year. She's only done 6 months of her PhD, but already made massive progress, as you will see. And her study aims to investigate how we can use genetics to optimize the way we treat people with psychosis. Over to you, Nushin.
Sorry, I was muted. Can you see my screen okay?
Yep.
Yes, yeah.
Lovely. So today I'll be speaking about my PhD project, which is investigating whether genetics can enhance care and quality of life in psychosis. So schizophrenia is a mental disorder which is characterized by positive and negative symptoms, as well as cognitive impairments. And people with schizophrenia have, on average, a shorter life expectancy than the rest of the population. And this is because patients have an increased risk in metabolic syndrome, diabetes, and cardiovascular disease. Compared to other chronic mental and physical health conditions, financial costs associated with schizophrenia are disproportionately high. And this is due to direct costs such as hospitalization and medications, as well as indirect costs such as loss of productivity and income losses. At the moment, schizophrenia treatment involves a trial and error process in which patients undergo several cycles of antipsychotic drug therapy until improvements are eventually reached. The patients are offered standard doses, and this is only altered if the patient experiences adverse symptoms. However, this approach leads to a very wide variability in the responses of the patients to standard doses of drug. So for example, the drug might have no effects in the patients, or it may cause negative side effects in other patients. And ultimately, this contributes to a low level of medication compliance and to the severe reduction in life expectancy among these patients. However, one potential solution is genetic testing. So after you take a drug, your body has to break it down and get it to the area that we want. Many factors can affect this process and therefore influence how you respond to the drug. So for example, age, your sex, the environment, and also genetics. Everyone's genetic information is different, and a genetics guided approach can tailor your treatment to each individual to take into account some of these differences in the drug responses. So my project is aiming to fill this gap by conducting a study to investigate the use of genetic testing to optimize the management of antipsychotic drugs. The primary objective of the study will be to investigate the effectiveness of the genetics guided treatment, and the secondary objectives will be to investigate the cost effectiveness and the acceptability of the treatment among clinicians. So this is an NIHR funded study in which my PhD is nested within. And in this study, we will be recruiting 420 patients, as well as 40 clinicians in the next 2 years. At the baseline visit, the patients provide a DNA sample, and then they complete a set of validated questionnaires, which are widely used in clinical trials in psychiatry. The intervention group undergoes genetic testing, and their doctor receives a report with the information on drug selection and dose adjustments based on their genetic profile. The control group do not undergo the genetic testing and just simply resume their treatment as usual. The patient is then followed up for 6 months. The clinicians are also participants in the study, so they're given a questionnaire to evaluate their opinion on the value of the genetic testing for their patients. And the final step will be analysing the data. So the 400 or so participants in the study will be compared to the control group of 1,600 individuals. And the two groups will be compared to determine the effectiveness of the intervention. I will then analyse the clinician questionnaires to evaluate acceptability. And finally, I'll be doing a health economics analysis to determine if the genetics guided treatment is cost effective. At the moment, we have 4 sites that have begun recruitment, and these are shown in purple. We also have 6 sites in England that are preparing to open. However, the opening of new sites has unfortunately been a slow process due to Omicron, but most of the sites are coming out now. So we are excited for progress to pick up in the next few months. So thank you very much for listening. And I'd just like to thank Mental Health Research UK and also my supervisors for their incredible support during this project. Thank you.
Oh, fantastic, Nosheen, really amazing project. I think precision medicine is certainly the way to go forward. And yeah, I think it's pretty amazing what you're doing with this project. So yeah, great work. I think that brings our session to a close.